Welcome to our Haematology series. This video is on vitamin B12 deficiency anemia. Vitamin B12 deficiency anemia is almost never caused by insufficient intake, as vitamin B12 is present in many foods and resistant to cooking and boiling. It is also synthesized by the gut flora. However, vitamin B12 deficiency anemia due to insufficient intake may occur in vegans. More commonly, vitamin B12 deficiency is caused by interference with vitamin B12 absorption. The physiology of vitamin B12 absorption starts with the release of the dietary vitamin B12 by peptic digestion. Cobalamin binds to haptocorrin, which is a salivary protein, and thus forms haptocorrin B12 complexes. Haptocorrin B12 complexes enter the duodenum, where pancreatic proteases are present. This leads to the release of B12, and then B12 attaches to the intrinsic factor. The intrinsic factor is secreted by parietal cells of the gastric fundic mucosa. When vitamin B12 attaches to the intrinsic factor, this forms the intrinsic factor B12 complexes. These then enter the distal ileum, where B12 attaches to cubilin. Cubilin is the receptor for intrinsic factor. Then B12 is taken up by enterocytes. Next, B12 is transferred across the basolateral membranes of the enterocytes to plasma transcobalamin, which delivers it to the liver and other body cells. Vitamin B12 is stored in the liver, and the reserve usually lasts 5 to 20 years. Possible etiology are interferences with vitamin B12 absorption. This can be caused by pernicious anemia, which likely occurs due to autoimmune responses to the gastric mucosa cells. This is associated with a loss of parietal cells, infiltration with lymphocytes and plasma cells, and megaloblastic changes in the mucosal cells, and this causes suppression of the intrinsic factor action. Gastrectomy causes the loss of intrinsic factor producing cells, and ileal resection causes the loss of intrinsic factor B12 complex absorbing cells. Disorders disrupting the function of the distal ileum can also cause vitamin B12 deficiency anemia. Examples for such disorders are Crohn's disease, tropical sprue, and Whipple disease. Other conditions associated with interferences with vitamin B12 absorption are gastric atrophy and achlorhydria. Generally, vitamin B12 absorption interferences are more frequently discovered in elderly and interfere with the production of acid and pepsin needed to release vitamin B12 from the food source. Macroscopic changes include the demyelination of the posterior and lateral columns of the spinal cord, sometimes beginning in the peripheral nerves. Later, axonal degeneration may supervene. The severity of the neurologic manifestations is not related to the degree of anemia, and the neurologic disease may occur without overt megaloblastic anemia. Signs and symptoms are nonspecific and may include pallor, fatigue, dyspnea, congestive heart failure, and mild jaundice, caused by increased erythroid progenitor destruction due to an ineffective erythropoiesis, as well as beefy red tongue, due to megaloblastic changes in the oropharyngeal epithelium and spinal cord diseases, progressing from symmetric numbness over tingling, burning in the feet and hands, and unsteadiness of gait to loss of position sense, especially in the toes. Often, these do not resolve even after B12 administration. The anemia that is found is macrocytic and later megaloblastic, and usually normochromic. Hypochromic red blood cells may be found if it is additionally associated with iron deficiency. Differential diagnoses include other causes of megaloblastic anemias, such as folate deficiency anemia and copper deficiency anemia. The diagnosis is based on a blood sample where autoantibodies blocking the binding of vitamin B12 to intrinsic factor or preventing the binding of intrinsic factor vitamin B12 complexes to cubilin may be found. These autoantibodies are useful for the diagnosis, but likely do not represent the primary cause of gastric pathology. Instead, autoreactive T-cell response is thought to initiate the gastric mucosal injury, thus triggering the formation of autoantibodies, causing the mass of intrinsic factor secreting cells to fall below threshold. Additionally, the reserves are depleted, and all of this together causes anemia. The diagnosis is also based on low serum vitamin B12 levels, normal or elevated serum folate levels, moderate to severe macrocytic anemia, leukopenia with hypersegmented granulocytes, dramatic reticulocyte response within 2 to 3 days to parenteral administration of vitamin B12, and pernicious anemia characterized by the above 5 characteristics, and serum antibodies to intrinsic factor. The treatment is directed at the underlying condition, but also involves vitamin B12 administration, but no folate administration. Folate administration may worsen certain neurologic symptoms of B12 deficiency. This video was part of our Haematology series, and it was on vitamin B12 deficiency anemia.